Hi everyone. Our article that we chose to do some research on was called The Assessment of Dietary Phosphorus Intake and the Implementation of Parental Phosphate Education in Pediatric Chronic Kidney Disease. And this presentation was done by Katya, Kranzley, and Luebbe.
Okay, so now let's take a look at some background information on phosphorus. We know that phosphorus is available in a lot of dietary sources, such as legumes and seeds, milk products, grains, meat and meat substitutes, preservatives, and processed foods. The daily recommended amount is 700 milligrams per day of phosphorus, and there is a upper limit of 4,000 milligrams per day, which does lead to toxic levels, which do increase the risk of joint and muscle pain, weakness, vascular calcification, and bone mineral disease. Phosphorus is also the second most abundant mineral in our body. Most phosphorus is found in our bones. More can be found as phospholipids in the intracellular membrane as DNA, RNA, ATP, and ADP. Some more phosphorus can exist as circulating phospholipids and inorganic phosphate. Looking at some key biological functions of phosphorus, we know that it is important for acid-base balance with maintaining normal pH in the extracellular fluid and intracellular fluid. It forms high-energy bonds such as ATP, creatine phosphate, and PEP. Phosphorus also plays a key role in gene transcription, regulation, and activation of other enzymes. Now I'm going to take a moment to discuss calcium and phosphate homeostasis and the importance of these elements working together in maintaining our metabolic functions. So calcium and phosphate balance exists at the intersection of four intertwined physiologic systems. Shown in the image on the right, we see that they work together for the GI system, endocrine system, renal system, and the musculoskeletal system. Starting on the left side of the image, calcium and phosphate enter the system through the GI tract, with some lost in the feces and some is absorbed in the bloodstream. About 60 to 70% of phosphate is absorbed through the diet, making it twice as efficient than calcium absorption. Absorption is influenced by vitamin D and, again, calcium. So when calcium and phosphate is absorbed in the bloodstream, there is a continuous exchange with minerals in our bones, as our bones are in constant balance between resorption and formation, which is also known as bone turnover. The endocrine system uses hormones to mediate the processes of the GI reabsorption, bone turnover, and tubular reabsorption. Both are also filtered in the glomeruli of the kidney, where some is reabsorbed in the renal tubules and the rest is excreted in the urine. Here is where excretion of phosphate is crucial in regulating all metabolic functions and preventing phosphate toxicity, because if the renal system is not functioning well, it will cause an increase in phosphate, which does, again, cause toxicity. The goal is to balance calcium and phosphate intake to have an equal input and output to prevent any imbalances. So going off from the previous slides of calcium and phosphorus homeostasis, we know that as kidney function declines, phosphate excretion becomes less efficient, causing serum phosphate concentrations to rise, leading to hypophosphatemia. Other conditions that increase the risk include advanced chronic kidney disease, hypoparathyroidism, and metabolic and respiratory acidosis. Hypophosphatemia is a condition where there is too much phosphate in your blood. Treatment includes making changes to your diet, medication, and dialysis.
Our purpose was to evaluate dietary intake of phosphorus in children with chronic kidney disease and to assess the utility of parental phosphate education for the control of hyperphosphatemia. Our research question was, will Will the use of parental phosphate education influence the dietary intake of phosphorus in children with CKD? And our hypothesis was parental phosphate education will decrease phosphate levels in children with CKD 2 through 5D. The study design is a prospective cohort study, which means that it's an observational study that observes a group over a period of time. The length of the study was March 2018 to September 2019, and the location was a CKD clinic. There were 75 subjects, children ages 2 to 18, and they all had CKD. And those that followed education due to hyperphosphatemia were 12 that were type 2 through 4, and then 24 that were type 5 to 5D. The inclusion criteria consisted of CKD diagnosis, and they had to be within 12 to 18 years old, and then the exclusion criteria were children that were on dialysis or were critically ill. Phosphorus intake was assessed by 24-hour dietary recall and analyzed using food processor software and then interpreted based on dietary reference intake, or DRIs, and suggested dietary intake, SDI. The interpretation of phosphorus intake was done using two different reference standard measures, the DRI and the SDI. Parents of those with hyperphosphatemia were subjected to a structured phosphate education. The education session encouraged interaction between parents, the nutritionist, and the clinician. An informational pamphlet was designed in 3 regional languages to address the importance of phosphate control, phosphorus content of Indian food groups, and cooking methods for phosphorus restriction. The pamphlets contain information on the role of phosphate in CKD, phosphorus content of food sources, plant or animal-based sources, use of food additives, the phosphorus pyramid, foods based on phosphate units, and specific cooking techniques to control hyperphosphatemia. And then the serum phosphate was monitored every 2 months for 6 months. So for our results, 70 out of 75 children that were screened were recruited, and about 66% of these children were boys, with the mean age being around 9.5 years old. Overall, in the cohort, about 50% of the participants had phosphorus intake exceeding DRI, with no significant difference between the groups. The mean daily phosphorus was comparable between children with and without hyperphosphatemia, and based on the DRI, 44% of children with normal serum phosphate and 58% with hyperphosphatemia had increased dietary intake of phosphorus. But then on the contrary, based on the SDI, 26% with normal serum phosphate and 94% with hyperphosphatemia had increased dietary phosphorus intake. And then overall, hyperphosphatemia was observed in 51%. So among 29 children completing 6 months of the follow-up, there was a significant reduction in mean serum phosphorus levels, which was independent of age, stage of CKD, or intake of phosphate binders.
Now, looking at the comparison to other studies that pertain to our current study that kind of matched the results that we found. Looking at education, increasing one's knowledge on a subject often has a positive correlation of effective results, which I believe that most of us can agree that increase in knowledge leads to a better outcome, as a lot of our PES statements in previous classes, a lack of education or nutrition knowledge is what causes a lot of problems, so increasing this knowledge is assumed to be beneficial. So this one study that was similar to our current study compared an intensive education program on improving serum phosphorus levels. The study found positive results in managing phosphorus concentration, minimizing risk of hypophosphatemia, and adherence to phosphate binders among hemodialysis patients. And a lot of chronic kidney disease patients have high levels of phosphorus, and there's been a lot of studies that showed a correlation from these chronic kidney disease patients with high phosphorus in their labs. So looking at this one study, it showed that there was clear association in chronic kidney disease stage 5 patients on hemodialysis with increased plasma phosphorus. Chronic kidney disease, mineral and bone disorder have shown abnormal levels of phosphorus, calcium, PTH, and vitamin D, resulting in abnormal bone turnover, mineralization, vascular and soft tissue calcification. As mentioned at the beginning of the presentation, a lot of foods do contain high amounts of phosphorus than we realize, which makes it more difficult to limit phosphorus intake. I know in the past, and I'm sure some of you guys have made a 24-hour recall of lowering the phosphorus level, and I at least found it very challenging because a lot of foods contained phosphorus than I realized. So that was very eye-opening on how much foods contain phosphorus. But anyways, there was this one study that did look at the association of dietary phosphate and kidney function. They did find that dairy products and grains contain inorganic phosphate additives that significantly increase serum phosphorus concentration even when consumed in small amounts. So even if you are lowering phosphorus intake, or like foods that contain phosphorus, obviously, it still has inorganic phosphate, which can still lead to issues. So that is important to take note of for future patients. And there was contradicting evidence as well from our study. This may prove that not every patient is the same, which no patient is the same, but it is important to, again, take note of. So these studies did not see a significant association between chronic kidney disease and abnormal phosphate levels. This one organization called the KDIGO has guidelines that suggest limiting phosphate intake to maintain serum phosphate concentrations in patients with chronic kidney disease stage 3 to 5. However, these studies did demonstrate that this strategy only minimally lowered serum phosphate concentrations or did not impact serum phosphate at all.
Okay, so some strengths that we came up with. The first one was that the study design, the prospective cohort study, was very easily tailored to collect specific data regarding phosphorus dietary intake and education sessions for the parents. The education sessions were also all the same for all the parents, so that kind of eliminated some parents receiving more or less information than others. A multiple pass 24-hour dietary recall for assessment of phosphorus intake was used as suggested by the clinical practice in the study, and as we know, this method, if done thoroughly, can be pretty accurate and is also a simple method for individuals to follow. And then, because the phosphorus dietary intake was assessed before the study, it was less prone to bias. Okay, so for some of our limitations that we came up with, those children with normal phosphate values ideally should have also received reinforcement through the structured education program on follow-up, but did not. Also, while 35% of children were hypertensive and on amlodipine, the phosphorus content in these medications were not considered in their intake. The bioavailability of phosphorus through diet remains a critical factor for the interpretation, and it was not undertaken in this study. A systematic assessment of adherence to dietary advice and compliance should have ideally been taken as well. And the assessment for protein energy wasting, dietary recall for phosphorus intake, and dietary assessment for calories and proteins on follow-up could have provided comparisons with the baseline dietary intake assessment, but that was not done. And then lastly, it is challenging to precisely estimate intake of phosphorus content of commercial foods because sometimes they lack appropriate labeling, and this can especially become an issue among non-urban residents, according to the article. Okay, for directions for future research, something that the authors suggested was exploring the impact of phosphorus intake and phosphorus education on long-term control of hyperphosphatemia and related clinical outcomes. Because this study is relatively short, it only lasted 6 months, and data was only recorded 3 times every 2 months. So, and then focusing more on prevention of hyperphosphatemia, we thought would be a good um, something good to research, and also examining the effects on early education for those with CKD to avoid abnormal lab values and future risks. And lastly, we thought it would be a good idea to explore the management of hyperphosphatemia in children and how else it may be improved besides the use of parental education, which is what this study mainly focused on. Okay, so we came up with 4 different discussion questions. Our first one is, one of the limitations of the study is the bioavailability of phosphorus through the diet. Do you think that should have been taken account of regarding specific foods that were consumed? Why or why not? The second one is, imagine you are a registered dietitian for a child age 8 with CKD stage 3. Your job is to educate the child and family on decreasing their phosphorus dietary intake to prevent hyperphosphatemia. What approach would you take in educating this family? The third one is, considering the results of the study and what we have learned about the inclusion of parental phosphate education, would you recommend all parents of children with CKD to take a phosphate education class? Why or why not? And then lastly, we have, create a meal for a CKD patient on low phosphorus diet. Was it difficult creating this meal? How much phosphorus does this meal contain? Okay, and then here is our reference slide. Thank you all so much for watching. Hope you guys learned something.